So much, Anne. I appreciate the flexibility of our presenters. You each gave wonderful presentations that have only further heightened my excitement about this area, because we're talking about real trials now. It's not just theoretical. So we do have time for some questions. So if any of you in the audience have questions, I invite you to come to the microphones, or anyone on Zoom can unmute and ask questions of our speakers. Okay, well, I will start off with a question. Daniel, you mentioned the fluctuating course of Natasha's epilepsy, and Anne, you and Mark also mentioned finding the right time to deliver the therapy. How is it that we narrow in on what is that right time? How do you think about that?
I guess I'll chime in for a moment. I mean, I think the time for many of our patients, if we're already diagnosing them and following them and on they're on med number 6 or 7, the right time was yesterday. So I think we are behind, and we have to think about that, but also not forget that whole group of patients who, we may not see the biggest change in somebody who's late in their course of disease, but there might still be a change. We've seen some nice examples from preclinical models where that could be the case. We need to sort of give that a try, but I think otherwise the right time is as early as possible. There's been some discussion about, could you do this pre-symptomatically? And I'm a little nervous about that because of all of the need for variant curation and all of the variability in disease severity for any given gene. But I think as early as we can diagnose kids and see that they're on a path to refractoriness or on a path to a known condition, it's not too early.
Thank you, Jackie.
Well, I just wanted to.
Oh, sorry, Daniel wanted to add to that.
I agree, as early as possible. And the other factor, the disease evolves. Seizure types, seizure triggers, seizure duration, seizure severity continuously evolves. And as parents, with the physicians, we try to use the available tools, medications, special glasses, controlling external heat, etc., to manage those cycles. So I think it's important for parents and physicians to understand that the disease changes, and what works for one patient at one phase of her life, it's not going to work continuously. So you have to continuously manage all the tools that you have, and not only to manage seizures, but something that you're always doing also is managing risk reward. You might control seizures, but you might increase other off-target effects. So you have to find the right balance. Many times we prefer to have low levels of seizures and not very severe side effects. So that's something that you're constantly trying to balance as a caregiver as well.
And if I can just sort of jump in on this one too. Sorry, guys. I agree with Anne. I think sort of the optimal time for identification was yesterday, right? But so as soon as possible for sure. But I think there's also the potential here, thinking about what our group does a lot of EMR-based work, right? We have a wealth of electronic medical record information, and when it's done in a standardized way, we have the ability to potentially identify patients based on very specific phenotypic features even earlier than perhaps one would have been able to do purely relying on just somebody thinking about sending genetic testing. Ingo Helbig has done some of this work. He talked about it, I forget if it was last AES or the year before, specifically in Dravet syndrome, and being able to use certain EMR-based features to find patients on average sort of 6 to 9 months before their genetic testing result was actually there. So we can leverage big data in that sort of way and accelerate that identification of patients to an earlier time.
That's a great example, Mark. Thank you. Jackie, and then we have one more question in the room and one on Zoom, and then I think we'll need to wrap up our session.
Okay, I was just going to bring in, for those of you who weren't at the research roundtable, we had a very robust discussion a couple of weeks ago about trials that would address seizures versus trials that would address some of the long-term consequences that we've been hearing about, and that the time frame within which you should test one may not be the same as the time frame that you would test the other. So, no parent wants to be in a placebo-controlled scenario where for a year you can't change any medication, but it may take a year for people to show changes in the long-term non-seizure outcomes. And we started thinking about the possibility of keeping medication constant for the 3-month period that we've all become acclimatized to, but then not unblind, but allow people to change medication after that, because the other comorbidities probably would not be impacted by changes in seizure medication. So I wonder what Daniel thinks about that. And I also wonder whether the companies in the room have thought more about that.
Yeah, I totally agree. And I think placebo-controlled studies are great. From one point of view, for caregivers and patients, it's brutal. We know, I mean, we've been in several trials. At one time, Natasha was having 30, 40 seizures every night. You go into a trial and you're probably we knew we were in the placebo arm, and we couldn't bear that anymore. So at the end, we got a special permission to go direct into the drug. So the shorter you do the placebo arm, the better. I totally agree with you. I mean, seizures as an endpoint is the easiest way to measure efficacy. And I think that other developmental phase is going to take much longer. So I think doing that, I mean, a short placebo control arm and a longer one on the medication to look at the other aspects of the disease is probably the way to go. And as you know, as you move, I mean, right now you have, I think in Dravet, some pretty powerful medications and new ones coming in to control the seizures. They are setting the bar pretty high in terms of seizure reduction. So I think when we talk about gene therapy or gene therapy type approaches, ASO and others, I think the bar is pretty high in terms of seizure reduction. So I think what we need to be measuring is the delta that's over that. And by the way, I think, like everybody said, that's what we all need to see. I mean, seizure control is not enough. It's about quality of life, and seizure is only a small part of quality of life. It's everything else. And that's why everybody's working so hard on addressing the root cause of all these genetic diseases. Yeah.
Thank you. Here in the room, and then we'll go to Zoom, and then we'll wrap up.
Hi, Peter from Stanford University, and so interesting session, and it's cool seeing this being brought forward with monogenetic epilepsies, but I wanted to see the thoughts on a lot of epilepsies are probably polygenetic, and are these things that can be translated, and where are we at using these same approaches to treating polygenic epilepsies as well?
That's like,
And I'll ask you to.
yeah, it's a great question. I mean, I was actually just going to say, separately, I was trying to find a way to bring this in that, we've been talking about these rare epilepsies. They're monogenic, they're often de novo, but I wanted to make a point to the room that anything that we learn about these, even if it's rare pediatric early onset epilepsies with a whole host of other conditions, is going to be applicable to epilepsy at large. There are lots of people with SCN1A variants in epilepsy that are not as severe as Dravet, but they're out there. They're similarly PCDH19 and DEPTIC5, and some of the genes that we found to be involved in some of the larger genetic studies. Yes, we're going to start with the youngest patients where there's the most to lose by doing nothing. And there's I think the most promise, because we can potentially treat early. But I think everything we learn about the rares is going to inform the common. How soon it's going to translate to people with polygenic epilepsy? We have polygenic risk scores, but we don't really have a handle on it yet in the same way we do the monogenic. So at some point, maybe, but I could see that, let's say there's a genetic trial for SCN1A. It's a big gene, so lots of people are going to have variants in this gene. And so let's say it's contributing 1/10 of the effect for an adult who's otherwise living their life and has an SCN1A variant. Could what we learn about Dravet and treating help that adult in the future? I think it can. So I think that's part of why we're motivated is the kids that we see and the severity. But I think the broader community should know that everything we learn about rare epilepsies is going to have effect on the rest of the community.